Okay, we'll go ahead and begin our webinar. Hello, I'm Mary Miller, EDX and ultrasound clinical educator at Cadwell. We want to thank you for joining us today for our webinar. EMG waveforms, recognition and significance of spontaneous waveforms, presented by Dr. Devon Rubin. Before we begin, I want to touch base on several housekeeping items. This live webinar has been approved for one asset continuing education unit. To earn the CE, you must attend the full duration of today's live webinar and complete a brief post-webinar survey about your experience. You must also have an asset ID number. Be sure to check your email inbox over the next several days for an email from Cadwell Education continuing the survey link. Today's webinar will include a live Q&A with Dr. Rubin at the end of the presentation. Please submit your questions in the Q&A box at any time. We will be monitoring them throughout the session, and we will address as many questions as we can during the live Q&A. Now, on to our introduction of Dr. Rubin. It is my pleasure to introduce our speaker today, Dr. Devon Rubin. Dr. Rubin is a professor of neurology and neuromuscular neurologist, electromyographer, and educator at Mayo Clinic, Jacksonville, Florida. He earned his medical degree at the University of Cincinnati College of Medicine and completed his neurology residency and clinical neurophysiology fellowship at Mayo Clinic, Rochester, Minnesota. Dr. Rubin has been active in research and educational endeavors related to EMG education within his institution, nationally and internationally, having directed and served as faculty in Mayo Clinic EMG in over 100 courses. He has developed a variety of novel digital educational programs and helped improve learning of EMG waveforms and performance of EMG, including programs such as EMG Waveform Trainer, EMG Recruitment Trainer, Muscle Localization for Needle EMG, and Real EMG Cases. Dr. Rubin has requested that an honorarium be made as a donation to the Muscular Dystrophy Association. This generous gesture supports the MDA's mission to improve the lives of individuals living with neuromuscular disease through research, care, and advocacy. Please join me in thanking Dr. Rubin for leading today's session. Dr. Rubin, I will now hand it over to you.
Thank you, Mary, for that kind introduction. It's a pleasure to be here. Welcome, everyone, wherever you are in the world, whatever time it is, whether it's morning, evening, or afternoon. I'm glad you're joining in, and hopefully we'll have a little bit of fun and learn something together this afternoon. So I'm going to just put my slides on here, and hopefully you can all see the slides. I love teaching. It's much better if we were all together in a large room, learning together. But so I'm envisioning everyone out there, and I'm going to envision you thinking about the questions I'm going to be asking you. And if you do have questions, as Mary said, please use the question and answer box. You can post them throughout the talk, and I'll do my best to try to keep track of the questions and try to answer them as we go along or towards the end. So I am going to be focusing on a very focused topic during this next hour, and it's the recognition and the significance of spontaneous EMG waveforms. And let me get my slides here. So this is a broad topic. What the main goal and objectives of this is to help review some of the skills that we use to recognize the different waveforms, not just spontaneous waveforms, but just any type of waveform. And we'll focus on the spontaneous waveforms and how to recognize them, and then we'll discuss with each one of these what they mean and how do we interpret the waveforms that we're actually recording at rest. We're not going to get into voluntary mode unit potentials. That's a whole nother topic. Maybe in a future seminar, we can focus on that. So let's begin by just talking about needle examination. So as you probably know, if you're performing electrodiagnostic studies, when we're faced with a patient that may have a neuromuscular disorder, and we're trying to sort out whether there's a neuromuscular disorder and what type of disorder, we have various tools that we can use in the laboratory to try to help make that diagnosis. So we have nerve conduction studies, and sometimes nerve conduction studies is the most important tool. For example, if we're looking for demyelination in a nerve, we're looking for conduction block or dispersion, we really need the nerve conduction studies. But many times the nerve conduction study findings just are non-specific, or they might even be completely normal. And we need other tools to make a diagnosis. And that's where the needle examination is so important. In many cases, many situations, the needle exam will show changes when the nerve conduction studies won't. So we have to be able to accurately perform and interpret the findings on needle exam. And sometimes we use other things like ultrasound to help us in making a diagnosis. So from the needle exam standpoint, remember what we're doing. We're putting a needle recording electrode into a muscle, and we're analyzing the electrical signals that are generated from muscle fibers as part of motor units in a muscle. And so there's a variety of different signals that can be produced by the muscle fibers, and being able to recognize those signals and interpret them requires a unique combination of knowledge and skill. And the skill is something that needs to be learned and trained to be able to recognize waveforms appropriately. So when we perform a needle exam on a patient, we do this in two situations in a muscle. So we examine a resting muscle, and we're assessing for spontaneous waveforms that are occurring in a muscle at rest. And then we have the patient contract, and you can see on the slide, this is my foot and I'm dorsiflexing. So if I was examining the anterior tibialis muscle, I would be recording the motor unit potentials and determining if there are changes in those potentials that indicate certain types of neuromuscular conditions. Both parts of the needle exam are important, but we're going to be focusing on the resting muscle today. So why do we need to examine a muscle at rest? Why do we need to record spontaneous waveforms? Well, the spontaneous waveforms, the variety of discharges, can give us some idea about the presence of a neuromuscular disorder and sometimes the type of neuromuscular disorder. So there are a variety of waveforms that we may encounter. We'll go through each of these in more detail. But the spontaneous activity can tell us about irritability or denervation of fibers. That's basically what fibrillation potentials tell us about. So if we record them, it tells us the muscle fibers are irritable or the muscle fibers have been denervated. It also can tell us about the excitability of some of the muscle fibers or the motor axons. So there are a whole bunch of different waveforms, all listed here in this purple box, that all the presence of which demonstrate or indicate that there's some hyperexcitability of the muscle fibers or the motor units. They're non-specific, though, and I think that's an important take-home point of this talk, as you'll see that most of these waveforms are very non-specific. That's very rare that we can make an actual final diagnosis based on the presence only of certain spontaneous waveforms. There are a few exceptions to that, which we'll talk about. And then sometimes the waveforms can tell us about pathologic changes in the muscle membrane or the channels along the muscle membrane, such as the presence of myotonic discharges. So this is what the spontaneous activity gives us. Again, just to repeat the point, many different types of disorders can have a variety of these different spontaneous waveforms. So we have to be able to analyze the motor unit potentials to really determine the type of disorder. So if we take a step back for a moment and we think about the origin of spontaneous EMG potentials, or really any EMG waveform, everything is generated by the action potentials of individual muscle fibers. And sometimes the muscle fibers fire by themselves, just one fiber that's firing spontaneously. That's what happens with Endplate or with fibrillations and myotonic discharges. And sometimes there's a group of muscle fibers that are giving off a group of discharges. And that group of fibers may be linked either by the fact that they're neighboring fibers, they're just next to each other, or they're part of the same motor unit. So they're a spontaneously firing motor unit potential, which is what happens with, which is what is fasciculations or myochymic discharges or neuromyotonic discharges, or under voluntary control, the voluntary motor unit potentials. So this is a good way of thinking about the origin, the very basic basis of the different potentials. But this classification doesn't really help when you have the needle in the muscle and you have this spike and it's going tick, 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 and you're trying to figure out what is that spike? Is it a fibrillation? Is it an end plate? Is it a motor unit potential? So this is where the skill comes into play. And there's a skill that you need to learn and need to master to recognize the different waveforms. And that skill really is the skill of recognizing different patterns of firing of waveforms. And we use our ear, our auditory system, to recognize firing patterns. Each of these different waveforms have a different type of firing pattern. Once you've learned it, it's actually pretty quick to recognize the different waveforms. And if you think about, for those of you who've been doing EMG for a long time, we spend much less time in a resting muscle than in a contracting muscle. It's more difficult to assess the motor unit potentials in different areas of the muscle and assess the subtle changes in those than it is to recognize whether there's a fibrillation or CRD or myotonic discharge. But you have to learn that skill first. So the process is generating this pattern recognition template. So we listen to the waveforms, we identify the firing pattern, we look at the configuration a little bit, we name it, and we compare it. And if you're starting out, if you're new to this, and I'm going to play some waveforms, and you might say, well, the end plate spike sounds like the fibrillation potential. It sounds exactly the same. And that's probably true. And I went through that process as well when I was first learning. But there's subtle differences in that sound of the pattern that can help you distinguish it. And that just requires some repetition to learn. Another important point is not to focus on the morphology, the visual morphology of the waveform, because different waveforms can look exactly the same. And the same type of waveform can have different morphologies. This is a nice old study where a muscle fiber action potential was generated in a volume conducting medium, and a monopolar electrode was placed at 5 different sites along the fiber. The action potential is generated halfway along the fiber. And depending on where the recording electrode is, the same potential looks very different. It could be a biphasic spike, negative spike. It could be a triphasic, predominantly negative spike, or it could be a positive waveform. So you can't tell what the potential is solely based on the waveform morphology. And that's a really important point. If you're looking at the screen and going, that's a positive waveform, that has to be a fibrillation positive sharp waves, you're probably misinterpreting some waveforms. So how do we recognize the different waveforms? By the firing pattern. And each waveform is going to have a different type of pattern of firing, a pattern of repetition. And this is defined by the predictability of when the next spike is going to fire. So patterns that are regular have a predictable interpotential interval change. It may be a change that's fixed. There's no change from interval to interval, or it might be a change that's a more gradual linear change. So a gradual steady increase in the interspike interval. And we consider those as regular firing patterns. You can kind of tap it out and you can predict when the next spike will fire. Some potentials fire in an irregular pattern. So that's a pattern where there's random intervals from spike to spike. Some are long, some are short, some are medium, and you can't predict when the next spike will fire. That's irregular. And then there's semi-rhythmic, which is what a voluntary motor unit potential fires in, where you can almost predict when the next spike will fire. There's a slight variation from interval to interval. So, this is good to understand. This is the knowledge part of learning how to recognize waveforms, but the skill part is training your ear to recognize the firing pattern. So I'm going to just play a couple. And normally, if you were in front of me, I would have you hold up your fingers for what you think the firing pattern is, 1, 2, 3, or 4 for those listed. So I'm expecting all of you, wherever you are right now, in your bed, at a restaurant, wherever, to hold up 1, 2, 3, or 4 fingers for whatever you think the firing pattern is. And hopefully that can be heard. I think I've shared my sound, so let me know if there's any problem hearing these. So if you've listened to it, and if you And if you held up one finger for regular firing pattern, you're correct. If you're at a restaurant, the waiter might be coming to bring you another glass of wine. But if you hopefully could hear that there's some predictability of that spike firing, you can tap it out. And if you have pretty good rhythm, you're going to tap it out pretty exact. It does slow down a little bit, but it's a regular, fixed, gradual, linear change. And that's a regular firing pattern. That's the pattern, as we'll talk about in a moment, that fibrillation potentials fire in. So if you can recognize that regular firing pattern, you don't even have to see what it looks like. You can recognize that that's a fibrillation potential. How about this one? So that answer is number 2. That's irregular. So there's some long pauses and some very rapid spikes, and there's no predictability to when that next spike is going to fire. That's irregular. That's what endplate activity fires in. So that's an endplate spike. And then this is one more. So I'm not going to make this easy and just go in order 1, 2, and 3. So this is actually 4. This is semi-rhythmic, and that's what a voluntary modium potential fires. There's some variation from interval to interval, but which we're not going to be focusing on today. So an important point, practice recognizing the firing patterns. That's going to make it much easier for you to recognize what type of discharge it is. So with that as sort of a foundation, let's go through some cases. So this patient might look familiar to you. This is a healthy guy who works hard, and he gets tired sometimes after a long day of work. And when he exercises, he notices some twitching in the muscles after he runs or exercises. So he Googled that, and he was a little worried and was wondering, what is this twitching going on? Does it mean anything? Is it anything of concern? So this was recorded from one of his muscles. And as you're thinking of the firing pattern, you have to take the whole clip. So keep in mind, if I just give you a little portion of the clip, it's hard to tell, but look at the whole clip of the spike. And if you answered 3 that this is irregular, you're correct. And you can see there's some short intervals, there's some long intervals, there's a medium interval. So there's no regularity or near regularity to this. This is irregular. So same clip. So if you recorded this, how would you interpret this? Is this consistent with an active radiculopathy? Is it benign fasciculations? Is it radiation? Or is needle in the end plate zone? And the correct answer here is number 4. This is needle in the end plate zone. This is the most common spontaneous waveform that you'll encounter. This is end plate activity. This is normal. We all have it. If you put the needle electrode in the end plate zone, you're going to record 1 or 2 types of discharges. One type of discharge, which I just played, is end plate spikes. So end plate spikes are these typically biphasic negative spikes that are irregular, and it occurs because the needle's irritated a nerve terminal, causing release of multiple quanta of acetylcholine, and that produces an action potential along the muscle fiber. And it's usually initially negative because the onset, the origin of the action potential is right where the needle tip is. So as the electrical field is moving away from the needle tip, we record initially that negative field and then a trailing positive electrical field. And it has this sputtery sound. It's an irregular type of sound. Sounds like fat kind of sputtering in a frying pan. The other type of activity is end plate noise. That's a much more rapid discharge. It's lower amplitude. It is irregular, but they fire so fast that it's hard to identify the firing pattern. And it has this seashell hushing type of sound. And that's the recording of the miniature end plate potentials due to spontaneous release of acetylcholine. And you can record either both of these, sometimes just noise, sometimes end plate spikes. So here's another example of end plate. I'm just going to tell you it's end plate, but this is some spikes and end plate noise. Here's the noise. So you can see these are little negative spikes, negative small rapid spikes, and that's the end plate noise. And hopefully you could hear that change in the baseline of the hush type of sound in addition to these irregular end plate spikes. So if you were recording this, what would you do? I would probably move the electrode to a different location because it's uncomfortable sometimes when you're irritating that nerve ending. So one or two more examples of end plate activity. And you can see a nice biphasic, initially negative spike. This one doesn't really have much noise. Again, irregular spikes. There's a little noise in the back you might be able to hear as well. So why do we care about this? Why am I teaching you end plate activity? Who cares? We all have it. Well, I think there's two reasons to be aware of this. One is, as I said, it might hurt. If the needle's irritating a nerve ending, you probably want to move the needle away from that area and redirect in another pass. And that's one reason why, from a technical standpoint, when you're performing the needle exam, moving the needle in small needle movements is really critical to reducing patient discomfort, because not only are you not jabbing the needle through the muscle, but you can listen and you can hear when you get close to the end plate zone before the needle's actually in there, and then you can pull the needle back and redirect. And then the second significance is just don't misinterpret these. Don't confuse end plate activity for fibrillations and call the patient, say that the patient has disease when this is a normal phenomenon. Okay, let's move on to the next one. Here's a spike, and I want you to listen to the firing pattern. So hopefully you listen, you can tap it out, and this is a regular firing pattern. And then think about what fires regularly. What does this sound like? What type of discharge? So this is number 2. This is a fibrillation potential. This is the most common abnormal spontaneous activity that we encounter in our EMG. And so let's talk about fibrillations. We could probably spend 45 minutes talking about fibrillations in all different contexts. But fibrillation potentials are the action potentials of single muscle fibers. So it's a single muscle fiber action potential that fires spontaneously when that fiber has lost its innervation. So it's a denervated muscle fiber. And what happens, and it gets complicated as to how these actually occur, but the thought is there's some instability of the muscle membrane and the resting membrane potential, and there's some oscillation of the resting membrane potential that's a regular oscillation, and a lower threshold for firing of that action potential, so you get this regular firing discharge, which is the fibrillation potential. So the key to identifying fibrillation potentials is they fire in a regular firing pattern, and that can be a fixed interval, a fixed rate, but usually fibrillation potentials will gradually slow down. It's a linear change in the firing rate until it eventually ceases. So that's the key to them. Now, there are some different morphologies to fibrillation potentials. There's a spike form that can be triphasic or biphasic, or there's the positive waveform, or sometimes people refer to positive sharp waves type of fibrillation potential. The morphology really reflects where the needle electrode is relative to where the fibrillation potential is being generated along the fiber. So if the needle electrode is kind of downstream from where the fibrillation potential is being generated, you'll record a triphasic spike. If the needle electrode is at the end of the fiber, or the fiber's been damaged by the electrode or by disease, you might only record a positive field that's moving towards the electrode and record the positive waveform. Both of them will fire in a regular firing pattern, usually with a gradual slowing down. So here's an example of a spike form. See a little triphasic spike. And here's a positive waveform. So in our laboratory, this differs from laboratory to laboratory. In our laboratory, we don't separate out in our tables fibrillations and positive sharp waves. So we just have a single column for fibrillations. I think of these as the same thing. Again, sometimes you can move the needle a little bit and the spike form turns into a positive waveform. So I think they both have the same significance, and I just consider all of these morphologies fibrillation potentials. And this just shows what I said a moment ago, how the morphology is generated. So if the fibrillation potential is generated right here and the needle electrode is a little bit distant to that, as the action potential is propagating, there's a positive field and the negative electrical field where the sodium channels are opening, and then a trailing positivity. So the electrode will record this triphasic potential like this. But if the needle's is damaged the muscle fiber, or there's a disease damaging the muscle fiber, then the needle will pick up more of the positive and a little bit of the negative field, and then the action potential can't continue to propagate. So that's what's recorded as a positive waveform. So again, regular firing pattern, single fibrillation. And sometimes they'll fire slow like this one. Sometimes they're a little bit faster. Here's an example of two fibrillation. There's a spike form, and then there was a positive form that's a little harder to hear. So here's another example, a patient who came in with clumsiness of the hand. This was from the first dorsal interosseous. So this is a bit more difficult. This is for the more advanced people here. So thinking there's a lot going on here. There's a lot of spikes, and you're probably thinking, oh, this is hard to determine the firing pattern. It's easy when there's one going tick, 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 but here's a whole bunch of different spikes. And these actually are all fibrillation potentials. This is dense fibrillation potentials. So it becomes much more difficult to recognize the firing pattern here. I will say that the sound of dense fibrillation potentials is different than the sound of end plate activity and motor unit potentials. There's subtleties in that, and that requires listening and comparing, but it does sound different than what you would expect or what you would hear with other discharges. And if you're not sure, sometimes if you hold the needle completely still, some of the fibrillation potentials will pitter out and eventually cease firing, and then you can hear the firing pattern of one of the spikes. And if you listen to the clickier spike or the louder spike, you might be able to follow that along and hear that it's regular. So that's a little easier there. Some of them cease firing, and now you can hear that spike is more regular spike. So we do grade fibrillations. The grade is subjective. It's qualitative. We don't actually count out the number of fibrillation potentials. If there's at least one fibrillation in more than one area of the muscle when we're moving the needle, we call that 1+. If it's moderate numbers, that's usually somewhere between 3 to 5 fibrillations. In multiple areas of the muscles, it's 2. If it's almost completely filling the baseline, it's 3+, and then really dense, completely filling the baseline would be 4+ fibrillations. So let's just give a couple of examples of different grades of fibrillation potentials. So that would be more 1+. Here's a 2+. And then 3+ is even more dense. That's the example I played at the beginning. So what do fibrillation potentials mean? What's the significance of them? So let's talk about that for a moment. As I said, they mean that the muscle fiber has been denervated, or the multiple fibers have been denervated if there are more than one fibrillation. That can occur in many different types of neuromuscular disorders. They can be seen in neurogenic disorders where there's been loss, where there's been denervation. That can be generalized neurogenic disorders like motor neuron disease. It can be seen in radiculopathies where there's active damage and the fibers haven't been reinnervated. It can be seen in severe mononeuropathies, severe axonal peripheral neuropathies. So they're non-specific and they can be seen in all sorts of neurogenic disorders. They also can be seen in myopathies. And that it's not in every myopathy, it's in myopathies where there's been separation of some of the muscle fibers from the endplate zone. So myopathies characterized by necrosis of the fibers or splitting of the fibers or vacuolar separation of the fibers. So those are classically the inflammatory or toxic myopathies or dystrophies. And then occasionally we see them in very severe neuromuscular junction disorders. They're certainly not diffuse or profuse fibrillations in those conditions, but I have seen patients with very bad myasthenia or LEMS or botulism where you have some fibrillation potentials. So the point is, you have to assess the motor unit potentials to determine the type of disorder. You can't just say there's fibrillations, this is this disorder. They're so non-specific. Now, there was a question about does positive sharp waves indicate a more acute injury? And that gets into a bit of a controversial topic. In some of the older literature, there's some suggestion that positive waves occur first, and then they develop into fibrillation potentials, the spike form. And that might be true in some situations, but I would really caution you on calling the temporal course of a disease based on the morphology of fibrillations, because there's so much overlap. In some acute conditions, you'll have positive waves and you'll have spike form, again, depending on where the needle is. And in chronic disorders, there's both positive waveforms and there's spike forms. So yes, there might be more positive waves and more acute problems, but you can't base the temporal course only on the fibrillation morphology. I will also say, and I hesitate to say this because I don't want people to misinterpret waveforms, but in really acute neurogenic disorders. So let's say you're doing the needle exam and it's been a 3-week-old process or 2-week-old process. Sometimes early fibrillations are not regular firing. Sometimes they're irregular. And I caution you, don't misinterpret irregular firing endplate spikes as fibrillations. And if I ever encounter a spike that I think is a fibrillation, but it's irregular, I'm much more confident if I find some regular fibrillations with it. But occasionally they can be more irregular early on. So we've talked about endplate spikes. We've talked about fibrillation potentials. Here's a little triphasic spike, and then here's a negative biphasic spike. So if I asked you which is which one's the endplate spike and which is the fibrillation potential, hopefully You're not going to say, well, this is biphasic negative, so that's the end plate spike. This is triphasic, so that has to be the fibrillation. Hopefully, you're saying to yourself or whoever's around you, I need to hear it. I need to see what the firing pattern is, because that's the correct answer. So here is this spike. And here is this. So this is regular. So this is a biphasic fibrillation. This is a triphasic end plate spike. It's irregular. So you really have to focus on the firing pattern. There's a question on how do you differentiate fibrillations from denervation from reinnervation. And I'll just make a comment on that. To me, you're going to hear different terms, but to me, a fibrillation means that the fiber has been denervated. Reinnervation is going to be based on the motor unit potentials. And so when you start reinnervating fibers and the motor unit's reinnervating and collaterally sprouting, the motor unit potentials under voluntary control are going to change in morphology. They'll become a little larger, they'll become polyphasic. Those are signs of reinnervation. Fibrillations don't mean reinnervation, they just mean a denervated fiber. So if, theoretically, if a fiber has not reinnervated, that nerve hasn't reinnervated a muscle fiber, the fiber is going to show fibrillations. And I think that gets to a really important point that can be complicated, that fibrillation potentials in and of themselves don't mean that there's an active process going on. So many of us are evaluating patients for radiculopathies. And the presence of fibrillation potentials in and of itself doesn't always mean that it's an active process where the nerve root is still being damaged. You can have leftover fibrillations from an old process in which full reinnervation does not occur to a muscle, and the fibrillations will continue indefinitely. So, for example, a patient who has a bad L5 radiculopathy, has bad foot drop, they find a herniated disc, they take the disc out, the pain goes away, the patient's doing great, but 2 years later, their foot drop never improved because it was so severe. If you put a needle in the anterior tibialis, there may be fibrillations. That doesn't mean there's still active damage to the nerve root. It means there was a process in which reinnervation never fully occurred. So keep that in mind. If I'm assessing a patient for radiculopathy, I like to see fibrillation potentials in distal and proximal muscles and paraspinals, ideally, to say that there's an ongoing active process. Okay, that's the most common spontaneous waveform, abnormal spontaneous waveform. Let's go through a few other less common ones towards the end here. So this was a 49-year-old man with gradual distal hand and foot weakness. He was tripping more, and this was recorded from multiple muscles. Okay, so what do you think the diagnosis is here? What do you think this discharge is? It has a strange firing pattern. It's speeding up and slowing down. And this is the pattern of a myotonic discharge. So that we're getting into some of the rarer discharges, but a myotonic discharge is a spontaneous waveform that's generated due to some defect or some abnormality in the muscle fiber membrane channels that causes a muscle fiber action potential to fire repetitively, and it repeats in an unusual way. It repeats in this pattern that may speed up and slow down in an exponential fashion. So it's a very rapid speeding up, a rapid slowing down, and it has this distinct sound that some people think sound like a dive bomber or whatever type of sound you want to put to it. But this is it's generated due to a problem in the muscle fiber, not a problem with the motor unit or the axon. It's a muscle fiber problem. So they can be slow and fast and long and short. So here's another example. So you can see these long, and you can kind of hear that rapid speeding up. You can see it a little bit, and it also will increase and decrease in amplitude as well. Here's a shorter burst of myotonic discharge. You can hear that speeding up. You see the amplitude increase. These can be completely spontaneous, or they're often induced by the needle irritating the fiber. So if you move the needle just a little bit, then it'll induce these myotonic discharges. So what do these mean? Well, actually, if these type of discharges can be really helpful in making a diagnosis if you find them diffusely throughout the patient, throughout multiple muscles in the patient. And if I find diffuse myotonic discharges, the differential diagnosis becomes much more narrowed. So usually that's a myotonic myopathy, either myotonic dystrophy or myotonia congenita, and there are some less common ones that I've listed here. Most of these will have clinical myotonia as well. And if you're not familiar with clinical myotonia, the way to identify this, one way is to percuss a muscle with your reflex hammer. And with myotonia, you'll get something like this, where the muscle continues to contract very slowly, and there's this delayed relaxation. And if you put a needle in that muscle, you're going to hear what I just showed you. You can also get infrequent isolated myotonic discharges in multiple other types of myopathies. So in some of the inflammatory myopathies and other myopathies, they may just be in one or two muscles. So not the diffuse myotonia that's in all the muscles. And then rarely you might get technically a myotonic discharge in some chronic axonal processes. The times I'll see them is in a patient that has an old peripheral neuropathy or old neurogenic disorder. I think this patient had a bad chronic axonal neuropathy. Actually, that wasn't the example I was showing, because they're usually not that prominent. It's usually a fibrillation that it'll quickly speed up and then it'll slow down. So technically it's a myotonic discharge. Okay, next one is a 56-year-old with proximal leg weakness. This was from the rectus femoris. So what do you think this patient has? An acute femoral neuropathy, recent radiation, chronic myopathy, or Parkinson's? And the correct answer here is 3. This patient had a myopathy. This is an example. I'll play it again. This is an example of a complex repetitive discharge, or CRD. So these are kind of interesting discharges. These are a group of time-locked muscle fiber action potentials that are part of different muscle fibers of different motor units, but they're neighboring fibers. They're time-locked, so a group of spikes fires repetitively in a very regular pattern. So this interval is very fixed, but there's often an abrupt onset, an abrupt ending, or abrupt shift in the number of spikes or shift in the rate. So it's complex because there's multiple spikes, but it's regular. And what distinguishes this from something like a myochymic discharge is a myochymic discharge, which I'll show you in just a couple minutes, is the same motor unit that's firing in a burst, and then the burst stops and then repeats. This is not the same motor unit in this group. This is a group of different spikes that are time locked to another. And this is due to some ephaptic spread of neighboring muscle fibers. So there's a pacemaker spike that's firing spontaneously, and then the action potential ephaptically spreads to neighboring fibers in a circuit until that circuit might stop, or that circuit might switch or change. And again, you can see multiple different spikes that are time locked. If you take this group and this group, they look exactly the same. So here's a couple of CRDs. This is a real slow, stable one. And you can see again, these spikes look different. So these are multiple different spikes that are time locked to one another. Here's a distant CRD. And you can see, again, see the little group here. It has a distinct sound. I think of this as sounding like a jackhammer. Some people say it sounds like a motor boat or motorcycle. It doesn't matter what you think, but if you need to be able to hear that regularity of that sound of a CRD. So what's the significance of these? Well, they're neat, they're really interesting, they're cool, but they don't mean a whole lot. So they're kind of neat to find, but they're seen in chronic conditions, both neurogenic and myopathic disorders. So again, chronic, C should stand for chronic repetitive discharges, but other than that, you can't make a diagnosis based on CRDs. We also published this study a couple years ago. We had a number of patients that the EMG was completely normal, except they had an isolated CRD in one muscle. And you can sometimes encounter this just in a muscle without any other abnormalities. We found them in a group of patients that had more likely C6 innervated muscles in the arm or L5 and S1 in the leg. So you have to be careful not to miss other abnormalities if you find this in one muscle. More often, there's going to be some neurogenic or myopathic disorder, but they can be isolated. Here's a patient that had twitching all over. He was a young, healthy man. He began to have twitching and some cramps all over, and he was concerned. And he came for an EMG, and we recorded this in multiple muscles. So if you think about the pattern of firing here, this is an irregular firing of pattern, and this is characteristic of fasciculations. He didn't have any other abnormalities, no fibrillations, the motor units were all normal, so in him it was actually benign fasciculations. But the point here is this is an example of pretty prominent fasciculation. So fasciculation potentials are spontaneous discharges that are now motor units that are firing spontaneously. Everything else we've talked about so far are muscle fibers that are firing spontaneously. Now we're getting into the spontaneous firing motor units. And I think most everyone is familiar with fasciculations. You probably encounter them on yourself. They're the random pops of the muscle that occur irregularly. And when we record those, the electrical potential is a motor unit potential that's firing spontaneously in an irregular fashion. So endplate spikes fire irregularly and fasciculations fire irregularly. So it looks again like this. Oops, that one's not playing. So and the morphology can vary. It can look like the morphology reflects the underlying motor unit. So sometimes if there's reinnervation in a disease, a neurogenic disease, and the motor unit potentials are really large, the fasciculation potential will be large. But many times the needle's kind of distant to the fasciculations, and so it's hard to identify the morphology. There's been a lot of work on origin of fasciculations, and basically the thought is that these can be generated anywhere along the motor unit, both at the anterior horn cell and at the nerve terminal. There's some thought that in ALS, it's more generated at sick nerve terminals than in benign fasciculations, but we don't fully understand that or know that. So where do we encounter fasciculation potentials? Well, again, like many of these discharges, they're nonspecific. When people have neurogenic disorders, there's a higher predisposition to fasciculations. So again, everyone worries about ALS or motor neuron disease, but you can get them in someone who's had an old radiculopathy or in a neuropathy. We will see them in hyperexcitable nerve conditions like cramp fasciculation syndrome, sometimes patients who are on mestinon or other medications. And then there's benign fasciculations, which are fasciculations in the absence of any other neurologic clinical findings or EMG findings. So where do I worry about fasciculations? Well, my concern follows the context that we find them in. So this is a patient that had lots of fasciculations, but he was having some slight weakness of his arms and his face. And he had fasciculations in multiple muscles, and his motor unit potentials, which this is the only motor unit potential I'm going to show you today, a voluntary motor unit potential, but this looked like this. And this isn't playing, but it actually has a long duration. You can hear it. It's a long duration motor unit potential. And this is a patient who actually had Kennedy's disease. So with long duration motor unit potentials and fasciculations, then I start to become more concerned. And just a point about identifying fasciculations, particularly in motor neuron disease, that, needle EMG is probably not the best test to identify fasciculations. And there's some good data that using neuromuscular ultrasound can be really helpful. It looks at a larger area of the muscle. And on ultrasound, this is a little bit dark and maybe hard to see, but you can see these twisting movements of the muscle, these kind of little pops of the muscle. And this is probably a better tool to detect fasciculations in certain muscles. And then the last discharge here that I'm going to show you is this. This was a woman who had progressive arm pain and numbness and weakness, and this was recorded from the pronator teres. So what do you think she has? This is a pretty classic discharge. She actually had a history of radiation injury for breast cancer. And this is a classic myochymic discharge. So now we're getting into the really rare discharges. A myochymic discharge is a motor unit potential that fires spontaneously in a burst. And these bursts recur over and over. They may be regular bursts. They may be semi-rhythmic bursts. Sometimes they're irregular bursts. And you can see in this picture of a myochymic discharge that the bursts aren't always exactly the same. Here you see more motor units repeating than in this group. So there may be some variability from burst to burst. But the key is that this is the same motor unit potential that's firing repetitively within a burst. And there's usually some variation from interval to interval, both between bursts and within bursts. And the burst can fire at a fast rate or they can fire at a slow rate. And they kind of have this marching sound. So this and neuromyotonia are part of a spectrum of peripheral nerve hyperexcitability. And there are a variety of theories as to why these discharges occur. There's some alterations in the axon environment. There may be some antibodies targeted against the nerve terminal, some voltage-gated potassium antibodies. Sometimes are associated with patients with Isaac syndrome or neuromyotonia. But we don't fully know why these occur. So what's the significance and what type of disorders do we think about with myochymic discharge? Well, the classic finding is in radiation. So someone who's had radiation in that distribution and you have myochymic discharges, it's almost certainly due to radiation injury to the nerve. But they can be seen in a variety of other disorders, and I've listed a number of these here, both focal disorders and more diffuse disorders like Isaac syndrome. We looked at a series of patients at Mayo Clinic that had myochymic discharges. We found 35 that had radiation-induced injury, and then 35 patients who never had radiation. And you can see here, they were seen in a whole variety. This is usually in an isolated muscle, not diffusely, but in a variety of conditions: mononeuropathies, radiculopathies, motor neuron disease. So again, very non-specific when they're just an isolated myochymic discharge. So here's a couple of examples. There's a fib, but the larger is a myochymic discharge, a larger discharge. So this is just repeating. And then, again, this is the same motor unit that's firing repeatedly. You can see down here in the slower sweep that this burst is just repeating very slowly over and over. Here's one that's a little more irregular. And then this is a patient that had carpal tunnel syndrome, and this is in the APB. It's a little tiny discharge. Again, it's broken up here a little bit. It's unstable too, but it's very regular discharge. The patient contracted there as well, and the discharge continued. And then one more just to show the morphology. When the burst is the same motor unit. Oh, my media is not playing on this computer. So anyway, that's myochymic. And then to end with a very, very rare discharge. Hopefully this is going to play. This is a neuromyotonic discharge. These are exceedingly rare. This is a motor unit that's firing very fast. It's usually 200 to 300 hertz. It has a race car type of sound. And this is usually due to diffuse hyperexcitable neuromuscular disorders such as Isaac's syndrome. So as I said, these are usually seen in Isaac's syndrome and a few other disorders as well. So that's a lot of information. Those are the classic spontaneous waveforms. I think the points to keep in mind, and then I'll go through a few questions here, is remember to identify the firing patterns. That's going to help you determine what the waveform is. Remember, the common waveform fibrillation potentials that we see in lots of patients is nonspecific. Doesn't always mean an active process. It's nonspecific. And remember, we need to assess the motor unit potentials to really determine the type of disorder. So hopefully that will help you in your practice. I'm going to take some questions here, I think. Is that okay, Mary? Can I go through some of these?
That's absolutely just fine. Thank you, Dr. Rubin, for sharing your insights with us. We'll go ahead and engage in the Q&A session now. If you haven't already, please share your questions to the Q&A box below. We have about 10 minutes or so to answer these questions live, and we will try to get through as many as possible. If you were unable to get your questions answered during our live session, we will follow up with you after the webinar ends. So let's go ahead and join in some of those questions. Dr. Rubin, I do have one question that is in a different area. I'm going to present that to you really quickly first. It is, can you explain the stable and non-stable spikes and their indication?
Yeah, so when I think of stable and unstable potentials, that's typically referring to voluntary motor unit potentials, although you can see them in some of these other discharges too. So when a potential fires repeatedly, let's just talk, I know this topic isn't motor unit potentials, but when a motor unit potential fires repeatedly in a normal person, a normal motor unit, and all the nerve terminals are giving off enough acetylcholine to generate endplate potentials and action potentials, the morphology of that motor unit potential will look exactly the same every time it fires, and it will sound the same every time it fires. So you have this potential that goes bup, 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 and that bup sound sounds exactly the same. That's a stable potential. That means every time that motor unit fires, that all of the individual muscle fiber action potentials that summate to form that motor unit potential are all firing. If you have an unstable potential, it usually refers to some defect in the neuromuscular junction. And that what happens is then every time the motor unit repeats, different action potentials are firing or summating to produce that motor unit potential. So the morphology of it will change. It'll go up and down and up and down and up and down each time it fires, and the sound will be different. The pitch changes. So it will go bup, 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 bup. It sounds different every time. So that's what I think of an unstable potential. It's changing, a moment-to-moment change every time it's firing. When you're doing voluntary motor unit activity, that can be classic for a neuromuscular junction disorder such as myasthenia gravis, but you can see those in neurogenic and even myopathic disorders when there's reinnervation and ongoing reinnervation. So, okay, I'm going to go through some of these that I see here. How long does a fib last in the denervated tissue? We should see fatty muscle atrophy once the tissue is denervated, correct? And shouldn't fibrillations die out over time? So that's a really good question. And the answer, and that you're exactly correct, that if a tissue has died, if the muscle fiber has died, has become replaced by connective tissue or fatty replacement, then the fibrillations go away. There's no action potential that can propagate along the fiber. How long that takes is variable, I think. I don't have a specific time frame. And that's why some people think, and there's evidence that the presence of fibrillations, even dense fibrillations, is not all that bad. I mean, I always joke that I'd rather have no fibrillations than have a whole bunch of fibrillations in my muscle. But the presence of fibrillations means that that muscle tissue still is viable. So, for example, in some traumatic nerve trauma, even if there's 3 or 4 plus fibrillations, that might mean that there can be some reinnervation to improvement in that patient. So, presence of myotonic discharges in patients with spasticity, particularly with Botox. So, you can get myotonic. So in spasticity in and of itself, without treatment, you really shouldn't have any abnormal spontaneous waveforms. Spasticity is an upper motor neuron problem. The lower motor neuron and muscle fibers should be fine. You shouldn't have fibrillations. You shouldn't have myotonic discharges. With Botox, and particularly chronic Botox, there is denervation of the fibers. And then there's reinnervation over time. So what often is recorded, and I don't give Botox, I don't do that in our practice, but I used to have an office right next to my wall to my office was right next to the Botox room. And so I could hear the people who used EMG guidance, I could hear the waveforms when they were injecting Botox. And you can get CRDs. You often get complex repetitive discharges in muscles that have had repeat Botox. I suppose you can have myotonic discharges. I think both of those would indicate that there's just been chronic denervation from the Botox over time. What do I think about very tiny sharp waves? Should they be taken as an acute denervation sign? So, again, as I said, I would not say that positive sharp waves in and of themselves mean it's acute. And the amplitude, I also don't put a whole lot of weight on. Part of the problem is the amplitude might change if you move the needle a little bit closer to the fiber. It might increase in amplitude. The amplitude probably reflects the diameter of the muscle fiber, and particularly the one area where often you get lower tiny amplitude fibrillations, and usually they're much slower firing, are in myopathies. So many myopathies, you'll get these tiny, very slow fibrillations that you have to pay attention to very carefully. But I don't think that's been systematically studied. And so I don't think you can put diagnostic value on the amplitude or the morphology of the fibrillations. I'd caution you about doing that. You really need to use the motor unit potential analysis to determine that. So how does EMG differentiate myotonic discharges from other abnormal muscle patterns like fibs or fascics? Well, my simple answer is review this webinar 10 times and you'll be able to figure that out. So again, they're very different. The patterns of firing, as I've said, are very different. And it's hard to describe in words. You have to kind of have tools and listen to the different discharges back and forth over and over. And once you've done that repeatedly, then you'll be able to hear the difference and train yourself. Let's see. I'm gonna just skip a few. If there's time, I'll come back to some. I'm gonna skip some of the motor unit potentials questions just for the sake of time. So let's see. What's the significance of waxing and waning myotonic discharges in diagnosing neuromuscular junction disorders versus muscles? So in a neuromuscular junction disorder like myasthenia gravis, as I said, you usually don't have abnormal spontaneous discharges. If it's severe, and those patients are usually very weak, then there may be fibrillations. You shouldn't have myotonic discharges. You shouldn't have other spontaneous discharges. I suppose you could have fasciculations if the patient is on mestinon, but you shouldn't have myotonic discharges or the others. So if you have a patient who has weakness and you're trying to sort out what they have, and they have profuse fibrillations, like some of the examples I showed you, that's probably not a neuromuscular junction disorder. So, does a phaptic transmission occur commonly in healthy myocytes? That's a good question. I think the answer probably is rarely. And I answer that because of the patients that have CRDs and don't have any other abnormalities. And we theorized in our paper, which we had to take out because there's no real proof, that maybe those patients had subclinical or radiculopathies, but we didn't see changes of reinnervation to support that. So in those patients that have incidental CRDs, I think that there may be some instability of the membrane and a few muscle fibers for reasons we don't know and produce the CRDs. What's the recommended gain for evaluating spontaneous activity? So most of these discharges are going to be pretty low in amplitude. So what I do is I use a gain of 50 microvolts per division. When I put the needle in, our machines are set to 50 microvolts per division. That's when I make my passes for looking for fibrillations and other spontaneous waveforms. Fasciculations are going to be larger. Myochymic may be larger. But you don't want to miss the fibrillations. And if you have your gain at 200, which is what we use for voluntary motor unit potential analysis, you might miss those smaller fibrillations. So I would start at 50 for spontaneous and then switch it to 200 for voluntary activity. So if we encounter end plate noise and spikes, how much do you move the needle to clear it up? It depends. I mean, I usually pull the needle back and re-angle a few degrees and go in a different spot. If I've moved a few times and I just can't get away from it, sometimes I'll pop through the end plate. If you kind of go through that, then the pain goes away. And some people they're not bothered by it, but it can be confusing because then you can't listen for fibrillation. So I'll just re-angle the needle a few degrees to get away from it. Okay, let's see. With the first dorsal interosseous pedis muscle, when would you consider spontaneous activity significant? Great question. So in foot muscles, and we're talking about fibrillation potentials. So in foot muscles, some people will have a few fibrillations, particularly as you get older, particular people who have trauma to the foot muscles. And so when do we worry about it? And the times that we would be sticking those muscles are patients that might have a very distal polyneuropathy, or if you're thinking about tarsal tunnel or something like that. I think if you find 2+ fibs or more dense fibs, that's probably abnormal. This is just my experience. There's no good data to support this. I think if I'm sticking that muscle in, I find 2 fibrillations and that's it, I probably wouldn't put too much weight on just a couple fibrillations there. But it really depends. I think that's a good muscle, FDIP. It's better than the abductor hallucis. It's not as prone to compression and damage. So I do like to examine that muscle. So can you comment on fibrillations and paraspinals? So another great question, paraspinals in the history of spine surgery. So if they've had spine surgery and those paraspinal muscles have been cut, they're damaged. And there may be some reinnervation to the muscles, attempted recovery, but they're damaged. And that damage, and this has been shown, that damage can lead to fibrillations that can be there for a long time, for years afterwards. They may not fully be reinnervated. So most of the time, if a patient has had spine surgery and I'm assessing them for a radiculopathy, I usually don't stick the paraspinal muscles. Now, the argument is if you stick them and they're normal and there isn't fibrillations, that helps you. But if there are fibrillations, I don't know how to interpret that. So I usually avoid sticking it for that reason. Is there a difference in spontaneous waveforms from concentric versus monopolar? I don't think so. Not in the presence of them. So most of the time, we don't really care about how big they are, what the duration of a fib is, how tall it is. I just want to know, are they there and how dense they are. So I think that there's really not any difference in identifying the different spontaneous waveforms. One could argue that the pickup area of a monopolar electrode is going to be a little larger than the pickup area of the concentric. So if there are some distant fibrillation potentials, you might not pick them up with the concentric. And that theoretically might be true, but remember, you're moving the needle through the muscle in multiple passes to try to find the fibrillation. So I don't think practically there's much of a difference. Okay, let's do a couple more here. We'll do 2 more minutes. So is there a difference in how long can a fib last? As I said, it can last forever. And how can you confirm recent acute lesion? That's going to be motor unit potential analysis. So fibrillations can be there usually after an acute injury, it usually is about 3 weeks. That depends on the length of the injury and the nerve to the muscle. Usually about 3 weeks is when they'll start firing. But if you have an acute lesion, the motor unit potential will just show reduced recruitment. And then as time goes on, you'll start to see more morphologic changes that tell you the time frame. And the last question, which I'm not going to give an answer to, is there a talk on motor unit potentials as well? That's a question for Mary. And hopefully someday there will be a second component to this and there'll be a talk on motor unit potentials. So
Yes,
I'll leave it at that.
yes, we'll look for one in the future for that for you per request. To finish out this webinar, thank you, Dr. Rubin, for leading today's session. We appreciate your insights on EMG waveforms. I also want to thank everyone who joined today's session. We appreciate you sharing your time with us. As a reminder, please look forward to an email from Cadwell Education with a link to the post-event survey in order to earn your CEU credit. If you have any questions about today's session, or you are interested in scheduling a demo with your dedicated representative, please reach out to marketing@cadwell.com. Have a wonderful day, and thank you everyone for attending. Thank you, Dr. Rubin.
Thanks. Enjoy your day or night. Bye-bye.
Bye.